And to finish with my third favorite abstract, we're going to get back to multiple myeloma. It was an oral abstract presented by Matthias in the Saturday session with a clinical trial, which was only a phase 2 clinical trial called the Redirect TT1 clinical trial, with a combination of two bispecific T-cell engager, anti-BCMA, which was teclistamab, and anti-GPRC5D, which was talquetamab. As you probably know, the BCMA bispecifics studied the development earlier, so they are currently considered to be probably a new standard in patients who are triple exposed. However, we know that the GPRC5D bispecifics are basically associated with more or less the same response rate and the same PFS. So the current sequence in 2023 at our clinical trial would be to consider BCMA targeting agents first and GPRC5D agents after, in case of relapse or intolerance sometimes. And the main question of this interesting clinical trial was the combination of those two different mechanisms of action, different targets at the same time, teclistamab plus talquetamab at the same time. It was a phase 1/2 clinical trial, so it was still quite early. Approximately 100 patients have been enrolled in this trial. The median number of lines of therapy was 4. The primary endpoint was the response rates, and the overall response rate was very promising, 86.6%. Just to remind you, the overall response rate with teclistamab alone is 65% approximately in the same subset of patients, and it's approximately the same with talquetamab. So it permits to increase by approximately 20% the overall response rate as compared to tecli or talquetamab alone. The median duration of response was not reached after a median follow-up of 8 months. And the thing which is also interesting is the overall representation of patients with high-risk cytogenetic characteristics and also extramedullary disease. And in this subset of patients with extramedullary disease, plasmacytomas, the response rate was the same, 85%, as the overall population. So patients with extramedullary disease who are well known to be much harder to treat, much more severe, basically are associated with the same response rate as the general population with no plasmacytoma. So we can conclude that this combination of two different targets of two bispecific at the same time is promising. Of course, we need to be concerned about the side effects. The side effects here does not, with the combination, does not appear to be superior to the level of side effects of each of those two bispecifics used alone in monotherapy. Of course, we have some level of hematologic toxicity, febrile neutropenia, but only 13%. As you probably know, those bispecific T-cell engagers are associated with a significant risk of hypogammaglobulinemia and a risk of bacterial and sometimes also fungal infections. But here we did not see a clear increase in the risk of infections, even if the proportion of patients with a grade 3-4 infection was 52%, which is quite a lot, but it's approximately equivalent to the level of infections, especially with the teclistamab. So of course, we need to be very concerned about this. We need probably to select the patients in whom we will be able to propose this combination. Only probably fit patients with no major comorbidities, but it's feasible, and the response rate appeared to be very promising, and it could be very interesting in patients with high-risk characteristics and, once again, extramedullary disease maybe. So, of course, it's very early. We need to run another clinical trials and some other clinical trials on the way. So we have to wait additional data, but it's feasible and quite promising.